Morning everybody, I'm Dr. Saurabh Verma and we'll be talking about applications of OCT in retina. In this presentation, we'll be going through the basics of OCT, use of various scans and modes which are available to us in diagnosing as well as treating various diseases, and go through recent advances and future directions. OCT is a very important diagnostic tool and can give us cross-sectional images of both anterior and posterior segment. It is non-invasive and based on the principle of low coherence interferometry, it can give us very high resolution images. Spectral domain OCT can have a resolution of up to 3 microns and a field of view of about 6 to 9 millimeter. Swept source OCT can have a resolution of up to 1 micron and a field of view up to 12 millimeters. OCT can help us in evaluation of vitreous, various retinal layers and choroid. It can help us in determining a line of treatment, whether it is surgical or medical. It helps us in understanding as well as explaining the prognosis to the patient and hence makes an overall difference in the overall management. While describing the OCT of macula, we should start by commenting on the vitreoretinal interface, followed by foveal contour. Status of each layer or sublayer should be looked at, whether it is continuous or disrupted, or is there any abnormal reflectivity in any particular layer. Central macular thickness should be looked at, and finally underlying choroid should be looked for thickness and presence of pachyvessels. While using OCT, we have the option of using these multiple scanning protocols. First one is the line scan, which is a single horizontal scan passing through the area of interest. Then there are raster scans, which are basically multiple line scans stacked close to each other over a predetermined area of macula. Then there is the radial scan, which are multiple tangential lines centered around fovea. There are 6 lines, 12 lines and 24 lines protocols available. In the 6 line protocol, the angle of separation is about 30 degree between the two lines, and here you can see as we move away from the fovea, the separation between the line increases, and hence if there is any lesion in between these lines, they are more likely to be missed. Hence lies the utility of raster scans, because even smaller extrafoveal lesions will be picked up very easily on these dense scans. Finally, there are macular cube scans, which are basically volume scans and give us an approximation of the thickness profile of retina over a predetermined area. So most important thing that we have to ensure while analyzing any disease is that these scans should pass through the area of interest. Now we'll go through some clinical examples. So diabetic macular edema can be classified morphologically with the help of an OCT. In spongiform macular edema, there is diffuse thickening of the retina with loss of foveal contour. Then there is cystoid macular edema, which is characterized by the presence of cysts in the retinal tissue, which might be accompanied with a neurosensory detachment. On the basis of location of macular edema, it can be classified either as center involving DME or non-center involving DME. If the retinal thickening is present in the central 1 millimeter subfields, then it is called center involving diabetic macular edema, as seen as in this image. So this was a 67-year-old male who was diagnosed to have a cystoid center involving diabetic macular edema along with some hard exudates at the macula seen as hyperrefractile dots on this OCT scan. After 2 anti-VEGF injections, macular edema completely subsided. So this is the scan of another diabetic patient. In addition to cystoid macular edema, here we can see that there is a thickened vitreous which is pulling the retinal inner surface. This is called vitreomacular traction, and such a scenario requires use of PPV. For removal of traction, and anti-VEGFs alone would not be sufficient. Dry RMD is characterized by presence of drusen's along with pigmentary changes predominantly at the posterior pole. These drusen's are seen as yellowish deposits in the subretinal space, which might be hyperreflective or hyporeflective on the FAF based upon their composition. And when we do an OCT, we can see these homogeneous deposits below the RPE. Reticular pseudodrusen's are characterized by deposition of similar material between RPE and ellipsoid zone, and they are known to increase the risk of progression to geographic atrophy as compared to a CNVM. Neovascular AMD is characterized by presence of a choroidal neovascular membrane. It can be classified morphologically on the basis of their location as type 1 or occult, that is below RPE, type 2 or classical, that is above RPE, and type 3, that is intraretinal CNVM. Presence of any fluid or intraretinal hemorrhages is suggestive of an active CNVM. Here we can see that there is a type 1 CNVM along with some fluid. This warrants the use of anti-VEGF injection in the said patient. Along with this, we can see that there is an overall increase in the thickness profile of the choroid with large pachyvessels present in the halar layer. A neovascular membrane can be beautifully seen in the outer retina of the patient on OCTA scan. So this was a patient of pachychoroid vasculopathy who presented with complaint of sudden diminution of vision. There was presence of subretinal hemorrhage, and when we did an OCT, we found that there was a large hemorrhagic PED. The hemorrhagic nature of the PED can be confirmed by shadowing of the underlying choroidal tissue along with splitting between RPE and Brooks membrane here. This is called double layer sign, and it develops because of development of a branch vascular network between these two layers. On this scan, we can see a large thumb-like PED along with a notch, aka notched PED. It is very characteristic of PCV. On this scan, we can see that the RPE is irregularly raised and a hyperreflective membrane can be seen both below RPE and above RPE. That is, there is presence of both type 1 and type 2 CNVM. Shallow retinal detachments, which are difficult to pick up on indirect ophthalmoscopic examination, can be picked up and confirmed with the help of an OCT. This is a patient with old retinal detachment with multiple subretinal bands in the macular region, and these bands are beautifully picked up on a scan passing through the macula. Extensive CR degeneration in pathological myopia results in poor contrast, and hence features of myopic traction maculopathy are difficult to pick up without OCT in myopia. In the first scan, we can see there is intraretinal splitting of the retina at the fovea. This is called foveoschisis. In the second scan, we can see a dome-shaped elevation at the center of the macula. This is called dome-shaped macula. This dome is causing a buckling effect at the center of the fovea, and hence there is no foveoschisis in this patient, but there is splitting of the retina around the dome. This is called maculoschisis. This patient had foveoschisis along with retinal detachment, and after VR surgery we can see how well the retina is attached along with disappearance of the foveoschisis. So this was a pathologically myopic eye which had a localized posterior pole detachment along with macular hole at the center. This macular hole was confirmed with the help of an OCT, and after VR surgery the retina was attached as well as the macular hole was closed. This was a patient of central retinal vein occlusion, and OCT confirmed presence of a diffuse macular edema along with a shallow neurosensory detachment. Hence, this patient was injected with anti-VEGF. This was a patient of CRAO, and OCT showed inner retinal hyperreflectivity, which is classically seen in arterial occlusions. A relatively recent advancement is development of OCT angiography. It gives us dye-less end-fast imaging of the retinal, choroidal, and optic disc vasculature. We can analyze vascular networks at various depths individually. OCTA basically detects the motion of blood using intrinsic signals to capture the location of blood vessels. Superficial and deep vascular plexus can be analyzed separately for various qualitative analysis. Artifacts in OCTA images are a major limitation of this diagnostic modality in clinical practice, and these artifacts are caused because of eye motion, misidentification of retinal layers, projections, or even low OCT strength. This patient presented with a grayish subretinal lesion along with some hard exudates at the posterior pole. OCT confirmed the presence of a type 1 CNVM along with neurosensory detachment. FFA showed some focal leakage, and a neovascular complex was beautifully picked up on OCT-A. This was a case of pathological myopia with extensive CR degeneration. A yellowish subfoveal lesion was visualized. On angiography, some leakage was seen corresponding to this lesion, and OCT-A scan confirmed presence of a neovascular complex. This was a patient of healed choroiditis where OCTA scan helped us in making a diagnosis of CNVM, which otherwise would have been very difficult to pick up on clinical examination. We can look at NVDs and NVEs. We can comment on the status of foveal avascular zone and determine the presence of capillary non-perfusion areas, particularly at the posterior pole. Microaneurysms can also be seen, though microaneurysms are known to be low flow lesions, and if we compare a OCT-A image with a corresponding FFA image, the total number of microaneurysms are likely to be more in the FFA image. The most recent advancement in OCT is the introduction of adaptive optics. It is a technique that corrects for optical wavefront aberrations, and once it is integrated into ophthalmoscopes, it enables retinal imaging at a cellular level. People have used it to study the health of photoreceptors and how the photoreceptors are affected by various disease pathologies. Its use is primarily limited to scientific works right now, and its clinical applications are very limited. In conclusion, OCT helps us in having a better understanding of the pathology, natural cause, and response to therapy of retinochoroidal and vascular disorders. Thank you.
So that was quite an exhaustive talk on the role of OCT in